Well, good morning, everybody, and thanks so much for the invitation, for the warm welcome, and for a great program. Thanks for the great debates, and IMEDEX for kind of like bring us back in person to those important meetings. So we have a lot to talk about, so these are my contacts. Again, you can scan another QR code if you'd like. This is not for the menu of the hotel. This is for connecting with me. So if anything, as many of you know, I'm more than happy to connect at any time, talk, discuss anything educational, research, or, of course, patient care. With this, these are my disclosures. And also, these are our learning objectives. So we have to evaluate the mechanisms, efficacy, and safety and indications for the approved tyrosine kinase inhibitors and treatment of HCC. We'll also assess same clinical efficacy, safety data, and approved and emerging tyrosine kinase combination regimens, because there are a lot of combinations that we can talk about. And to develop treatment strategies for HCC to include evidence-based therapeutic selection and adverse events management to optimize treatment outcomes. So to address all of that, we have quite extensive agenda, as you can see over here. And we're going to start with some very important basics. And it's very important to really reiterate them many times because, as we all know, HCC is not really like a classic disease that oncologists take care of. This is like really the new kid on the block in a way. And we have to really go to the basics to really make sure that we all together have the same kind of length or width of information that's available for that purpose. Biopsy, like why would you even bring this up? Like, of course we do biopsies. Like how do you treat any cancer without biopsy? Well, interesting in HCC, there's at least a school of thought that maybe we don't need a biopsy. And this has been in debate. And the debate literally is about like close to about 25 years ago. Because if you recall, there was a screening mechanism to really try to find out if any lesion occurred in the liver to figure out if it's cancer or not, so we can really accordingly either take it out or offer transplant for the patient. And of course, you want to, every time you see a little nodule in the liver on ultrasound, you cannot just keep poking needles in that liver because ultimately people will get a lot of biopsies more than needed. So there was a suggestion of very basic components that, if the liver is cirrhotic, and interesting here, we can put the first question mark, what's cirrhotic liver? If anybody has a perfect answer, please hop on the plane now to Sweden, you get the Nobel Prize for that, because nobody has a clue. And number two is, the tumor has to be of a certain size, and of course, if it's bigger than a certain size, we don't know. Colleagues in radiology carried on with that information enough that ultimately, to give them credit, came up with what they call the LIRAD, and it's kind of like a certain assessment radiologically to tell if it's cancer or not. And it was carried on. LIRAD is not a simple, regular thing that any of us can read. You have to have an experienced radiologist to understand it, and it has a caveat in regard to what's really cirrhosis or not. Nonetheless, we carry on enough that some of the oncologists among us will say, oh, LIRAD 5, that's it, HCC. Well, we have to pause here and kind of, be attentive to what we say because even the person who built in LIRAD altogether, and I give him credit, he really is a superb speaker. He was at the ILCA, the International Liver Cancer Association in Madrid last September, and he was debating for yes for or no for LIRAD, and of course he was for the yes. But interestingly, and he's clearly stated that we never tested the LIRAD data or the LIRAD mechanism of evaluation of the HCC in advanced metastatic disease. So we don't have data. In other words, all what you're trying to claim in regard to LIRAD really is never tested in the setting that we are all involved in regard to medical oncology. And then I'm not really sure why he said that, but he said, well, I don't know if it's kind of like, nobody even triggered that question, but he said, oh, medical legal consensus are in my subconscious only. And I wasn't really curious, like, why did you bring it up? And then I went and searched it, and believe it or not, in 2022 alone, there were 2 cases that went to litigation, malpractice, because of LIRAD diagnosis of HCC that was wrong. Because as you can imagine, you can understand the expanse of things that you can diagnose in the liver, among which, for example, the cholangiocarcinoma, some other variants of diseases. So you can imagine that this is not really satisfactory, and this already has been at least 2 discussions of that nature, and that's why probably he brought up that statement, even though nobody asked. And then thirdly, I have to say this is probably his classic cynicism. He said, oh, can you tell me about any targeted therapy for HCC? And myself, like subconsciously, I'm telling him, oh, maybe you should talk to Dr. Javli. Maybe he will let you know. Because this is really where the future is like look at targeted therapy, see what it means, and accordingly, apply therapy. But guess what? If we don't have the biopsy, if we don't analyze the biopsies, we're not going to ever know. And to be fair, to give credit, many of us have been involved in, and including some of the work that we did at Sloan Kettering, where we pretty much tried to delineate with the biopsies that we have, and to be fair, because we don't have expansive biopsy, because only we depend on what we have internally, we were able at least to delineate 3 pathways in regard to how HCC develop. And could there be targets? Yes, FGFR4, FGF19, you name it, could be there. But the question is, if we don't get the biopsies, we'll not be able to delineate any further information of that. So if anything, my first message, please make sure you do biopsy for patients with liver cancer, because you cannot go, if you are ready to stand and say, that's it, I guarantee with my whole life that is HCC, I think you really have to think very carefully about that. So with this said, there's another component that comes into play, which is the scoring and staging. And that's a little bit of a variant that really apply only to HCC, which is we're not really dealing with the cancer itself, we're dealing with the cancer and the liver function all at the same time. And we kind of have been looking into many different scoring and staging systems, enough that jokingly every town started having its own scoring system, and we couldn't really read, understand each other. And as you see, many of those different scoring systems has a lot of those green dots means applies to, or parameters that apply to above the green line apply to the liver function, and below the green line apply to the cancer itself. And if you ask me which one to use, no idea. And if anything, we did the exercise, and we found that actually the most reliable ones are a little bit more complex than usual, among which the QP, Chinese University Prognostic Index, that apply mainly for hepatitis B patients, the CLIP, Cancer of the Liver Italian program, apply mostly for patients with hepatitis C related HCC. But if anything, we ultimately settled, we said, you know what, just stick to the Child-Pugh. And this is really, by the way, you see all those clinical trials having a Child-Pugh. Let me tell you one thing, it's not as scientific in any way. We were actually at a meeting used to run called the East-West Liver Meeting. Back in 2002, it was in, or 2001, it was in Houston. And we could not come to an agreement of anything. Said at the end of it, said, okay, Child-Pugh. That's what it is. So all those Child-Pugh you see in the clinical trials is where it's coming from. And so what's Child-Pugh? I mean, I remember during my residency at Yale, I mean, all what I see, you tell me Child-Pugh, I'll freak out. That's really what I remember of it. Because it's like 5 parameters. You see, like, what's the connection between them? But actually, there is a story. Because the way livers kind of get sick is a very sequential matter. First, usually albumin, followed by bilirubin. Ascites start developing. Then you have the encephalopathy, and then the PTNR get worse. So this is a sequence. It's not like really at random one or the other per se. And then you add how extensive the damage is in each one of those parameters. You end up with a point from 5 points minimum, because you have 5 parameters, 1 point each, all the way to 15 for 3 points for each. Very important, though, to really imagine this is not ice cream flavor. This is not like A or B or C. Oh, I have a A or B. No, this is a sequential. It goes from A to B to C in a very, very choreographed way. But it's not linear. It's not A to B to C at the same rate. Actually, if anything, it's exponential. A is like a long, long line from Chicago, around the world, back to Chicago, and we're still in A. Enough that you tell a patient, oh, about Child-Pugh A, he'll say, oh, I don't remember. Nobody ever told me that. And then B is a little bit of a curve, and C is a shoot. And that's why our job is to make sure that patients are in A as much as possible, because most of the benefits from therapy can happen. And this is really where we have most of our therapies that can apply. This is where they were tested anyway. So this is really where you kind of like have to keep the patients as long as possible. In the old days, used to kind of, come with the crying sound of medical oncologists, oh, I don't get the patients because they're all kind of like, taken care of by interventional radiology or surgeons. They don't send them to me. I only see them when they're B and C. Well, guess what? This is not the case anymore. Because if anything, we're realizing with all the therapies that are available that patients are to be seen earlier, and they are being seen earlier for treatment and evaluation. But very important, when you kind of, state a statement about patients, say X-year-old lady with blah, 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 HCC, comma, child PU score X. Otherwise, you don't complete your story if you don't really put that in. So this is kind of like the basics. So let's jump on to a little bit of more approach in regard to therapy. Now, therapy is kind of, understood always when you have early disease, you take it out. Early disease, bad liver, transplant. Local advanced disease, this is where you kind of depend on local therapy. And this is where you can see it right in the middle of the BCLC criteria, another form of criteria that was built in Barcelona. If anything, however, now we see this kind of like arrow that you see horizontally from B to C. It seems that finally there was an acknowledgement that yes, by all means, some patients with local advanced disease can benefit from local systemic therapy, not only local therapy. And to give credit, there's even an update on that one. Dr. Maria Rieg from the BCLC has built in, which really shows actually a specific category for BCLC B3 that will apply, where systemic therapy will apply. So why is that? Because this is historical. This is from 20 years ago. If anything, you have the patients with local advanced disease. You embolize, which means because you give arterial blood supply embolization, the tumor die. There was an improvement in survival, 3 years. All of us were like, wow, this is beyond impressive. And interestingly, however, if you look in that paper specific, and this is like really taken out as a picture from the paper itself in the Lancet, the median size of the tumor, as you can see at the bottom, 52, 49, 5 centimeter. That's all what we're embolizing. And any of you, I'm sure you tell me that your colleagues and our colleagues, wherever they are embolizing way bigger tumor than this nowadays. Interestingly, we kind of were part of that. We actually did compare bland embolization to chemoembolization, part of an NCI grant at Sloan Kettering, and we did not find any difference. That's not why I'm showing this today. But if you look at the bottom row again, you see that the mean size of the tumor, 7.7, 8.7 is about 8 centimeter, bigger than the 5 centimeter that we're just spoken about. And yes, we did not see any difference in regard to bland or chemoembolization. I'm not trying to preach here in regard to bland is as good as chemo, but more importantly, what's the median survival? Median survival for the chemoembolization nowadays is 20 months. 20 months, that's it. So keep in mind that really, this is really what can embolization do nowadays in regard to what we do. And if anything, there was a concern about like how much you can push the envelope. So our colleagues in Japan, Dr. Kudo and colleagues, brought in a little bit of an argument that said, it depends on the size of the tumor and depends on how many tumors there is, we might not benefit from local advanced disease therapies or local therapies. And they counted what's called the up to 7 criteria. How many lesions in the liver? Let's say 4, so you add number 4. What's the size of the largest lesion in the liver? Let's say 4 centimeter. 4 plus 4 equal 8 is more than 7. Interestingly, it was found that patients who have more than up 7 criteria can fare better with regard to systemic therapy. Enough that he did the study. That's a little bit of an analytical study. This was not randomized per se, but it was like a retrospective analytical study, but still it was valid. And interestingly, it doesn't matter which drug it is, but nonetheless he used here lenvatinib as a systemic therapy versus chemoembolization for patients with local advanced disease with beyond up 7 criteria. And as you can see here, the mean survival for the patient with chemoembolization was 20 months, 21 something, so 20 months. Same like as we just showed you from the data from Sloan Kettering. On the other hand, as you can see for the lenvatinib, 37.9 months, 38 months. This is likely 3 years plus. So as such, I'm not saying, okay, now it's time for us to bring all those patients from IR and protect them in our clinics. No, the idea is to make sure the multidisciplinary team have discussion, engage. Please make sure you go to the tumor board. Actually, we noticed that across the board, the doctors who don't come to the tumor boards mostly for HCC are the medical oncologists. So please be there, because if you don't really express what you really could offer and make those kind of, statements in regard to what could be valid or not, patients, of course, are going to be embolized. So that's really what's important about the beyond up 7 criteria. So Let's, with this, remember also that we can hurt livers. Actually, this was done in the KUDO, where the ALB score, another form of scoring, which depends on albumin bilirubin. When you embolize a patient with beyond specific criteria, as you can see, ALB score in red goes up to 2 from grade 1 to grade 2, while for the blue with the lenvatinib remained in grade 1 specifically. So again, as we said, the summary of that part is chemoembolization is an appropriate therapy, but only when it applies to patients with locally advanced disease that are not beyond the observing criteria. Systemic therapy could be applicable, and of course, multidisciplinary team discussions are always very valuable for that purpose. So let's jump on to the core piece of the matter, which is got to systemic therapy. And we're just on with the first-line treatment. Now, there are two types of people, and we are two types of people. Some of us like to read Kaplan-Meier curves. Some of us like to read maps of mechanism of action. So if you like it that flavor, I have it. I have it in the other flavor too. But here, just kind of like to show what it is. It's complex, and no question, it's like really will require a little bit of transitioning component. But I would like you to focus on the key elements of it. All that tyrosine kinase inhibitor business is right in the core of the nucleus you can see there. And these are transitional components that include, that's why it's called multi-tyrosine kinase inhibitor. It has a lot of inhibitors that can happen along the pathways. And some of them could be really core central, like some of them is like lenvatinib. Some of them could be a little bit marginal, like, cabozantinib. But they still will benefit because they have a specific target, because remember, the cabozantinib specific targeting of, for example, c-Met and the AXL is also applicable a lot for the liver, because liver is full of hepatocyte growth factor, which really applies to the targeting of the c-Met, for example. So it doesn't mean like where it is, but it applies if it really fit in regard to the liver or not. On the other hand, you see to the periphery, the checkpoint inhibitors story that we're going to talk quite a bit about as well. And if anything, the checkpoint inhibitor story is dependent on the PD-1 and PD-L1, and I never claim that I'm an immunologist. I'm not an immunologist, but I have to really kind of, catch on the fly and learn what immunology is. So basic terms, always really the best way to do this. And these are probably good, by the way, to translate what we're talking or think about to patients as well. So always I kind of like simulated with like, the T cells are kind of like hanging around, coming from the lymph node, and they come next to the cancer cell. The cancer cells pick up the phone and say, guys, we're friends. Just leave us alone. Don't bug us. We don't bug you. So they offer them a nice chairs. The T cells sit on it. They never touch the cell membrane surface, like the floor right underneath where you're sitting now. But the minute anti-PD-1 come into play or anti-PD-1, they kick the chair out and the T cell fall onto the cancer. That's all what it is. And now, interestingly, we know that you need some communication between the boss, whoever that is, along the pathway for the kicking of the chair to happen, anti-PD-1, anti-PD-L1, and those tyrosine kinase inhibitors or some other mechanistic of action, which we'll dissect in details in a second. But however, to be fair, to build that story, to kind of be able to have that very complex structure, we have to start somewhere. So we started, of course, with sorafenib. And if anything, sorafenib as a tyrosine kinase inhibitor, at that time, it really was understood as a anti-BRAF, and that's really where we thought later on, maybe not, and anti-VEGF, and now we know it's targeting many different targets per se. It showed improved survival. As you can see here, 10.7 months versus 7.9. Superb. For the first time ever, we have a therapy for patients with liver cancer. So that was really a very important mechanism that we're able to apply now and have positive results from in patients with HCC. So for about 10 years, it's not like we're doing nothing, but enjoying the celebration of the success of sorafenib. We tried many things, and we say we, like really across the world, like everybody involved in HCC tried everything possible. We could not get anything better than sorafenib. And then interestingly, a novel approach came into play, which is the anti-FGF as an add-on to tyrosine kinase inhibitor, because it really sits in at the cell membrane, kind of like core top level. And the plan was to compare it to sorafenib because it's standard of care. But interestingly, they came with the idea, you know what? We are not going to claim we're better than sorafenib. And why is that? Because after all, we are both tyrosine kinase inhibitors. We don't think there's mechanistically anything that's going to make it any difference. And if anything, however, we'd like to kind of show that we're really equal to sorafenib. But at the same time, you remember, now that you decided that you are on a racetrack of a certain distance and you're going to run certain length, that's it. This is survival. and now survival is adding on to different like relay runners, one after the other. So yes, had like, 12, 13 months per se. But interestingly, can you have a faster runner on the field? Yes, you can. And that's where the PFS of the lenvatinib was about 3 times higher, and the response rate was about like 25% by RECIST, modified RECIST close to 50%. So as such, this was a positive study, despite that it's non-inferiority approach. There's not like a sneak way to get it, but this is really a totally scientific argument that was totally valid in that setting and became another standard of care. And the PFS, as I mentioned, was 3 times higher, and this was reflective also in the response rates. But of course, ultimately, despite that, all of this is happening, still we're kind of like, we have to acknowledge that we have some improvement, but not up to the kind of level where we want it to be. This is just to kind of like put it a little bit in summary for the 2 studies. We should not compare studies, but we all do. And if anything, you can see over here that the survival kind of evolved in the sorafenib, because now remember there are other players onto the field, so that's why it went up to 12 to 13 months. And at the same time, we can see that the response rates in the sorafenib are super limited, but in regard to the lenvatinib, they're definitely robustly there, and we all see them in clinic. And then when it comes to the adverse events, very important to remember, sorafenib, the classic, if I say the word sorafenib on the street, people look at their hands, because everybody's worried about the hand-foot syndrome. And to be fair, this was really kind of not pleasant for the patients, and at the same time, it's not pleasant even for the physicians to see their patients dealing through this. It's not like lenvatinib is like perfectly without any side effects. It does have them, but controllable blood pressure, weight loss, the reduction of the dose can probably help you with it to really make it applicable for patients. So, this is like a long list, just in case any of you would like to really look into it in more details, it's available. Sometimes we have to, because sometimes every now and then we might really be concerned about certain activities specifically that could apply for the treatments per se, among which, for example, potential bleeding. Remember, these are anti-VEGF. Now, they're not as potent as bevacizumab, but they still can cause bleeding as well. So anyway, this was the whole story in the central core, you remember, of the nucleus. But then we jump on all the way to the combination therapies. And this kind of, was an incredible improvement in outcome that came out from the combination of a anti-PD-1, being the atezolizumab, plus anti-VEGF, which remember now we're talking about a anti-VEGF, same like as the core of that tyrosine kinase inhibitor, but a little bit more potent, being bevacizumab, which we're all familiar with. And if anything, this combination, as we can see here, showed an improvement in survival. Numbers that really we never thought of that can happen in HCC, 19 months. Like incredible improvement in outcome that we never thought of. And if anything, this became a standard of care and became definitely readily available for everybody. For the patients, especially if there is no contraindication for checkpoint inhibitors. And of course, there was a requirement in the study, and please, very important to still apply it. You need to scope the patients before you apply the therapy, because the patients can bleed. And they can bleed, they can die from bleeding. So for varices, you need to always do the endoscopy before you do the therapy per se. Now, all of you say, with the positive outcome from a study, as many as you get an answer, you bring more and more questions. And one of the questions still hanging around, even though I have to say kind of, the perspective is evolving over time, is the issue of the anti-drug antibody. It appears to be that all the checkpoint inhibitors, without any exception, will and can develop anti-drug antibody by the body against them. It's like almost like an allergic reaction. And on that platform, we can see that on one extreme, the durvalumab and pembrolizumab have barely any anti-drug antibody. On the other extreme, you see it to the extreme right, the extreme left, you see atezolizumab stand out about 50%. Not sure why, but interestingly, the FDA was so kind of adamant about this concern, enough that they brought it in the package insert for the atezolizumab. And to give credit to the colleagues who ran the IMbrave 150, reported it at the AACR back in 2021, and they showed actually patients with anti-drug antibody negative, in other words, there's no antibodies, they did great. Actually, you see the hazard ratio is like close to 0.5, couldn't be any better in green. On the other hand, patients with the anti-drug antibody positive, they did not do well at all. Actually, atezolizumab plus pembrolizumab was as equal as it is to sorafenib. And you see it in red. How many of those patients? 30%. So 1/3 of the patients right off the bat will not benefit more than what tyrosine kinase inhibitors can do for them. And what shall we do with that data? We're not really sure, but it's something that becomes a little bit of a more of a reflection. And maybe in the beginning we didn't have much of a, more than that reflection, but now we have other choices. You might say, okay, but I can do this or that. But this, I leave it up to you. You can decide how you'd like to evolve with that data, but at least you know it. On the other hand, and this is back to our cancer immunity cycle, we spoke already about the anti-PD-1 and PD-1 at the bottom, which you can see it at point number 7. The anti-VEGF is at point number 5, which is where the bevacizumab will apply. But can you choose other things on the pathway? Yes, you can. And actually, the lymph node is a very central one because this is really the big boss is, like the chain of command for the immune system in our body. And this is really where actually the CD28 sit in the lymph node will always convince two important pathogens, which are CD80 and CD86, to do the job and send that message to kick the chair out the anti-PD-1 and anti-PD-L1. They kind of like drink kind of like some kind of like robust coffee, and this is what happens. Well, then some guy, CTLA4, come into play, convince CD86, you know what, let's hang around together. They kind of drink some heavy alcohol, they fall asleep, and nothing happens. And this really kind of, what occurs in all those activities of CTLA4. Interestingly, then anti-CTLA4, whatever that is, will come, take away CTLA4, let CD86 do the job, and pass the message all the way down to the cell membrane level. By the way, this kind of like simplistic and light joking approach that I'm talking, this is a Nobel Prize, by the way, in 2021. This is like really what actually Jim Ellison and other colleagues brought in for the Nobel Prize. So what does this translate into? The Himalaya study, interestingly, combination of durvalumab as anti-PD-L1 plus tremelimumab as anti-CTLA4 showed an improved survival about 16.5 months compared to the sorafenib 13.7 months, clinically and statistically positive. Interestingly, tremelimumab was given only once for the patients, and we still give it only once, because the robustness of the anti-CTLA4 of the tremelimumab is more potent than actually the CD28 itself, 3 times more potent. So that's why it's enough to give it once in the lifetime of a patient, and then you carry on with the durvalumab. On the other hand, we compared durvalumab to sorafenib, and there was no difference at all, 16.4 or 16.57 compared to sorafenib. This was done for non-inferiority because of what we have seen with other checkpoint inhibitors as single agent. Please, because this question I get asked like every time, so why do I need tremelimumab? The numbers are the same. No, remember in the REFLECT, we just spoke about it with the lenvatinib, the non-inferiority design does not imply that the numbers are the same. The 16-month of the durva-tremi is different from the 16-month of the durva by itself. And the durva-tremi is a very critical component to add on together to ensure you get the best benefit. And this we can translate, you can see it at the tail of the curve, with 36% of patients still alive at 3 years. We've never seen numbers like this. So now, of course, the challenge is going to be for many of you is what if I play around with this a little bit more? Not really. This is a good one. For example, atezolizumab plus cabozantinib did not work. Why is that? Because it seems PFS is not really a good endpoint for the checkpoint inhibitors. OS will always work better. And interesting to remember that as much as I said cabozantinib is critical to assess, to attack in regard to the hepatocyte growth factors in the liver, but it's really a little bit marginal in regard to the cell immunity cycle that occur to really cause that effect. And then there was the lenvatinib itself as anti-VEGF. We just spoke about this. That was a little bit shockingly surprising, not sure how to interpret that data. This was at ESMO last September in Paris. And pembrolizumab plus lenvatinib compared to the lenvatinib plus placebo was negative. 21.2 months for the pembrolizumab lenvatinib and 19-point-something month for the lenvatinib plus placebo. Everybody was like, whoa, I mean, like, what's happening here? Because you have what exactly you wanted to, and the response was negative. To be fair, we can't really comment much about this study because one component is there's no paper out. It's only based on abstract format. And even though the presentation that was presented at ESMO did imply that 1/3 of patients did get checkpoint inhibitors as second line after the lenvatinib plus placebo, but we don't know more than that. Add to this, we have some demographic component, but now we know that demographics does matter. because everybody will benefit, by the way, from checkpoint inhibitors. However, interestingly, when it comes to patients with hepatitis B, they fare the best, followed by hep C, followed by the non-viral like NASH and alcohol. And that's why, by the way, if you look at the details of the study of the AMBRAVE 150, it was 50% hep B, while the Himalaya was about 30% hep B. And then there's a revision of the AMBRAVE 150 done by the real AB study in the UK, where 30% were hep B, the mean survival went down to 15.7 months. So if you ask me, like, was it better or worse? I think they're all the same. It's not like really there's much of a difference. But that's why an important message, if any fellows or residents are hearing this, please don't just compare numbers. You have to look at demographics, like who is the patient, before you're really able to conclude any of that information. So let's wrap up. We have a couple of minutes to look into second-line therapy. Cabozantinib, a very robust tyrosine kinase inhibitor, which, as we said, attack the c-Met, AXL, VEGF. And if anything, we have shown that it has an improvement in survival, enough that it's 10.7 months or so compared to placebo. It was approved in second and third line therapy. And one of the arguments that really we did, if you recall, there was another drug called ARQX, whatever. It really showed positivity because we did not select for the patient. This applies for everybody. It's not like, oh, I want only to give it to high c-Met patients. Actually, this was the argument that we brought in, and we proudly were able to show that it does benefit patients, and it's a very appropriate therapy per se. And the adverse events are right broad over here. I know we kind of expressed a bit of nervousness with the drug because from experience that many of you have from other cancers among like renal and thyroid, but in general, it's appropriate and applicable. 60 milligram, you bring it down to 40 if need be. And mainly, you will see that tardiness fatigue is the key element that might apply, and of course, to some limited head-foot syndrome as well. Ramucirumab is an anti-VEGF. That's kind of like was a little bit of an interesting, convoluted story for the ramucirumab that ultimately was approved for patients only with AFP more than 400. What does AFP more than 400 means? We have no idea. Is it like a prognostic? Is it a diagnostic? We're not sure. Could be there were more sick people because mean survival here was only 8.5 months. We don't know. But however, I would say the drug does work. I have experience with it, and definitely it's an option that might kind of be used as a backup plan at some point in time in drug therapy. Regorafenib is an interesting variant of the sorafenib. Funny enough that at the great debates back in 2019, before even we kind of decided that we're going to do everything virtual until now, we spoke about regorafenib at that time, and we made an argument that actually there are actually certain mechanistic variations into it in regard to certain targets, among which IGF and others, that really will make it valuable as a second-line therapy after sorafenib. And if anything, prior sorafenib exposure, good tolerance to sorafenib will be critical to get the benefit from regorafenib CC with 10-month median survival. Pembrolizumab, kind of a checkpoint inhibitors that was looked against versus placebo in second line, was ultimately approved by the ODAC mechanism with a voting of 5-4. It's available for us. We can apply it if patients did not get checkpoint inhibitors as first line, as a second line. But if anything, it gives us a pause, most importantly. Is it really about binding things together, or is it about sequencing things together? Because is it like lenvatinib followed by pembro, which could be applicable over here, or is it about lenvatinib plus pembro, which, as we saw, was negative? We're not really sure, but there's a lot of question in regard to those sequencing versus combining that's going to come into play. Nivolumab, ipilimumab is another combination of anti-CTLA-4, anti-PD-L1, still in conditional approval in second-line therapy. We're waiting to see what the clinical trial will ultimately evolve and show us, but it's another option that could be available for you as well. The NCCN guidelines, at least good news, is now busy and rich in regard to HCC, and there are many options per se. I would say that always my statement on the NCCN guidelines are made in downtown Philadelphia. They're not made in heaven. So they're really kind of like dependent on what we think as physicians, and our colleagues really do a great job in regard to that. But please, we have to remember they really are to kind of, evolve as things happen. And I hope that nivolumab will be pulled out, because already even the company pulled it out from the market, so I'm not sure why it's still there. And at the same time, we'll see how the other options will evolve over time. So this is really in brief for anybody who really would like to kind of get the 5 seconds elevator pitch summary of what I just spoke about. Here it is. We have so many options in first-line therapy: atezolizumab, durvalumab, sorafenib, lenvatinib. In second line, we have regorafenib, cabozantinib, ramucirumab, pembrolizumab, nivolumab, and ipi plus nivo, and cabozantinib in third line. And hopefully we'll get some cleanup further of that table per se. Last word. Sadly, as much as we are kind of like fascinating ourselves with all of this, we have to remember that in our community in the Western Hemisphere, it's not like where the HCC patients are. They are actually in other places in the world, especially in Sub-Saharan Africa, in Northern Africa, and in Southeast Asia. In addition to that, even in the US, despite that they're really where they are, not everybody has access to the same thing. I have to give a lot of credit for actually an effort that was done by one of the bright fellows from the NCI that actually presented it at the GIASCO, where actually, for example, the Hispanic population has the least access to clinical trial for HCC in the US. And this is where kind of, as much as we are very proud of all the efforts and we are all very involved in, but sadly at the same time to realize that we're not doing that good job because we are not providing access to therapy. This is like an obligation that we all have. We actually did bring an effort in Africa that already we have in abstract format, and hopefully manuscript will come out soon. It was acknowledged by the White House last December. Believe it or not, after all that kind of fancy stuff we spoke about, 84% of the patients in Africa have only access to sorafenib. That's really what it is. So that's really where we have a lot of obligation on our part. Anyway, these are my contacts again. I don't know why they are in the back as well, but anyway, they are here.
We'll move into the question and answer session, and I don't see anyone here yet at the microphone. So we have a case-based number of questions from our virtual audience. So I'll just go through the case and then go through the questions. So a 64-year-old white male with a new mass that was 12 by 6 by 5 centimeters in the right liver lobe, biopsied as HCC pseudoglandular with an AFP of 106,000, but also Hep C that was just diagnosed as part of the workup, genotype 1A, viral titers 10,000. Apparently no cirrhosis by biopsy. Had yttrium 90 beginning of March, then LFTs bumped for 2 weeks later. Pain also increased that required narcotics. So here is question number 1. What systemic treatment to start? Atezo-bev or dual immunotherapy, or should one wait because of the residual pain? So we'll start with that question.
Yeah, thanks. I feel like I'm sitting for the board exam here, but so number 1, a comment before I answer. It's a very intriguing story that we just heard. And by the way, it could be like this is what happened. But patients with Hep C don't usually express high alpha-fetoprotein. This is really kind of related to the mechanistic component. It's more of a Hep B story. So 100,000 Hep AFP is more of a Hep B story. But nonetheless, we'll take it. Of course, there's an exception to every rule. With this said, this is still a disease that kind of is locally advanced, and at the same time, there are symptoms, as we just heard. There's pain, and interestingly, we don't have a rule when we switch from local therapy to systemic therapy. This not was decided anywhere except in Japan. In Japan, they decided among themselves. They sat all together, and they really, as you can measure, I give them credit, they are very regimented in regard to 3 local therapies, no more than 3 months in between, no less than 3 months in between, then we go systemic therapy. But over here is going to be a little bit more for a debate. Probably a discussion that should be including, of course, the colleagues in IR, and decide if they feel satisfied or not in regard to the treatment. Now, let's assume we are okay to go treatment only to answer the second part of the question. Which options offer therapy over here? I don't have really any personal preference that I would say. Atezolizumab is appropriate, but make sure endoscopy did occur. And of course, durvalumab is appropriate as well. Either of them will be an appropriate option of therapy.
And then the additional questions, what about treating the hepatitis C? Would you treat now or wait until the HCC is under better control? And whether to push for more aggressive approach with liver transplant?
I knew this is coming, and there's a C option of the answer, which is, or do nothing. Because interestingly, the data is debatable quite a bit. it appears to be on one hand, if the Hep C is there, is like the cat is out of the bag already. Because the way Hep C works is a RNA virus. By the way, B and C have nothing to do with each other. They were just standing at Starbucks back to back, and that's all that got B, C. That's all where it's coming from. One of them is DNA virus, which will affect on genetic material, which is Hep B. Hep C is an RNA virus, doesn't even talk to our genetic material. And as such, it's all about damage and repair. You have like somebody sitting in the factory, and they're kind of like putting one nail in one specific hole. By the 4 o'clock, it might go in the wrong hole. And this is exactly what happened in Hep C. That's why it leads to ultimately liver damage and repair, ultimately lead to cancer per se. And as such, because the event already has occurred and there's cancer, what is happening to the virus itself does not matter. Interestingly, it's totally different in regard to Hep B, because Hep B can still trigger more activity of the cancer, so that's why you treat the Hep B. But for the Hep C, there's data that probably not. On the other hand, there was a concern also of maybe adding more malignancy. We've seen actually even with the Hep C, if you treat it while there's cancer, you can get other malignancies, and that's been reported. But on the other hand, also there's another story that now we are seeing more and more of, that maybe there's a protective mechanism. I would say we don't have a complete answer in regard to that. I think probably this part, you need to make sure you engage your colleagues in hepatology, have a discussion about really the applicability of treating or not, and see what's really best for the patients based on the therapeutic intervention you're doing.
So along those lines, there are a few questions related to first-line treatment based on the etiology of the HCC. And I guess it was intriguing that Hep B had the best outcomes with immunotherapy, and just some thoughts on why that is.
Sure. So to answer the question first, the checkpoint inhibitor therapy applies for everybody. It's not like it applies to one versus the other. On the other hand, the mechanistic components have been probably understood in snippets in different work. To give credit mostly for Dr. Pfister, there's a paper, you probably saw it in Nature a couple of years ago, that showed actually that viral HCC will fare better with checkpoint inhibitors compared to non-viral. The way this study was done, it was a totally preclinical work, but took a little bit of a leap of faith and compared it to the clinical data that already has been reported. And of course, we translated it all wrong. We said, oh yeah, that we should never use checkpoint inhibitors in patients with non-viral. This is not really what Dr. Pfister and colleagues said. They really tried to explain the mechanism. And what's the mechanistic component per se? You kind of like have a induction of the CD8s that actually can be committed to kind of, be part of the mechanistic pathways of the Hep B. And it appears to be they're kind of like what we call exhausted CD8 cells that kind of like carry on the pathways all through for the checkpoint inhibitors. Interestingly, in the paper itself said we are not sure what these CD8 cells are or those exhausted cells are. So that's why I'm saying it's snippets of pieces of information. And that's really where the clinical part shows that Hep B patient will fare best, followed by Hep C, followed by non-viral. But everybody still will benefit. So that's why the answer is, yes, give it to everybody, but you might be surprised that your patient with Hep B might do best in regard to that therapy. Where are we going with this? At the moment, one of the efforts that we're doing at Sloan Kettering, we're actually doing a deep analysis at the RNA-seq level as well as genome level of patients from different cohorts from all over the world. That's really dependent on ethnicity, etiology, and exposure to therapy. And we're trying to see what mechanistic component will play a role. Because I would say the future of HCC, same it is for other cancers as well, it's not going to be more like one size fits all. It's going to be custom made. You have this following variables, that's why you offer the following to the patients, and there's what's going to come. But until then, it's still applicable for everybody with anticipation that Hep B will fare a little bit better.
A question about someone who's post-first-line immunotherapy. What TKIs do you prefer to offer, and in what sequence?
Sure. That's a very fascinating point to bring in that I brought up back in 2020, right before the pandemic, and kind of brought in the concept of cold line -1. Because here we are, we're giving, let's say, durvalumab, atezolizumab, what have we, and then we're going to just jump on to cabozantinib, skip the lenvatinib, for example, or sorafenib. Does it make sense? And that's why we brought up the concept of line -1. In other words, after you do the checkpoint inhibitors, because there is a mechanistic value for the lenvatinib and cabozantinib, you can apply them, and then after that, lenvatinib and sorafenib, you can apply them, and then you come back to the second line being cabozantinib, etc. So for that reason, I would say we should not really take the assets away. And as such, if you come with checkpoint inhibitors, re-engage the lenvatinib as an example, as a second line, quote unquote, line one therapy after the use of checkpoint inhibitors.
All right, we have a question from the audience.
Well, what's happened to the status of the fibrolamellar pattern of Hep C, of hepatoma? Is it increasing with the increase in hepatoma, or is it a completely separate entity?
So thanks so much for the question, and I really appreciate you bringing this up. So just to give a little bit of background, fibrolamellar carcinoma is a cancer that happened in the liver, but it's not HCC, has not to do at all with hepatoma with HCC or liver cancer. It's a totally different beast. Proudly now, there's an effort that really will bring in a new ICD code 10, actually, for fibrolamellar carcinoma, and to differentiate it per se. Interestingly, if you pick up the phone and call the FDA and say, hi, by the way, I have a headache, they'll tell you Tylenol. If you tell them I have fibrolamellar carcinoma patient, they'll tell you I have no idea, because there's no standard of care. This is really how sad it is. 200 patients worldwide, mainly median age 20, more girls than boys, and there's no standard of care. And if anything, we're not necessarily seeing a rise, but we're seeing actually a more acknowledgement of it, more openness about it, and a realization that probably it's happening in more parts of the world than we can think of. And I would say the right answer for this therapy-wise is clinical trials. And proudly, and we are very grateful for many of the sponsors that they really understand this is not really a way to kind of like build a business around a drug that you might give to 200 patients, but nonetheless, they are taking the good, good approach of trying to make sure we try something. At the moment, we have the AG1181 plus bevacizumab therapy, which all of you are excited about in colorectal and lung cancer. We have a study for that in fibrolamellar carcinoma, and there are others as well that are available per se.
And then maybe just a last question about biopsying. What are the barriers to getting biopsies, and what about using circulating tumor DNA, for example?
So there is no true barrier for biopsy, because one of the arguments that sometimes I hear from colleagues saying, oh, but the patient has a lot of varices and their Child-Pugh score is C. Well, then the question is, do you really need a biopsy anyway? Because, the therapy for Child-Pugh C, sadly, it is best supportive care and hospice care. Mm-hmm. So this is really where, yes, no biopsy. But in regard to Child-Pugh A, usually there's no problem. And if, let's say, the platelets are a little bit low, well, guess what? There's something called platelet, and we can give it, and we can really kind of be able to really circumvent that. Add to this, ctDNA is, no doubt there's a lot of futuristic component for it, but we're still not sure really where to put it in. ctDNA looks to many of us as being like the marketing is way ahead of the discovery, and we probably are using it quite a bit, but not necessarily really interpreting it correctly. So I would say we need the tissue still to be able to understand better, and hopefully one day we'll have the ctDNA, but not there yet.
Wonderful. Well, with that, we will end this session, and we are now going to a 30-minute break. The room will be closed. Please make your way to the exhibit hall, and we will return back at noon for our last two sessions.
That we're giving. And we assure you we'll be quick and to the point.
Yes.
Thank you very much.
Thank you very much.